Validation of the prodromal symptom screening scale in a sample of acute coronary syndrome patients. Globally, hundreds of thousands of people seek medical attention for report of ischemic myocardial chest pain. A considerable number experience unrecognized warning signs, scientifically known as prodromal symptoms, of a forthcoming acute coronary syndrome. Prodromal warning symptoms are a common occurrence for those suffering with coronary artery disease, with the prevalence ranging between 49 to 92% in both men and women. While the risk of waiting to seek emergent medical attention for signs of myocardial ischemia have been widely studied and knowledge dissemination provided to the public, poor recognition of prodromal symptoms remain evident in clinical practice. The aim of this validation study was to evaluate the validity and reliability of the prodromal symptom screening scale in a sample of men and women with coronary artery disease. Participants completed the prodromal symptom screening scale as part of a larger observational descriptive correlational study. Only the cross-sectional data relevant to the evaluation and the psychometric properties of the prodromal symptom screening scale are reported here. Cognitively intact adults admitted to a community rural emergency department who were differentially diagnosed with unstable angina or had non-ST elevation myocardial infarction, reported prodromal symptomology, had chest pain lasting greater than 20 minutes, or chest pain described as anginal equivalent symptoms such as dyspnea, nausea, vomiting, chest pressure, fatigue, dizziness were recruited. Once eligibility was established and an informed consent was obtained, ACS participants completed baseline demographic and clinical information questionnaire and the prodromal symptom screening scale related to the symptoms, frequency, and intensity of cardiac-related prodromal symptoms as seen on the slide. The prodromal symptom screening scale identifies 9 cardiac-related prodromal symptoms, including unusual located aches and pains, unusual fatigue, sleep disturbances, chest pain, anxiety, headaches, dizziness, and shortness of breath. To thoroughly describe patients' unique prodromal symptoms, the category of other symptom, item 9, was offered to patients in order to capture all subjective prodromal symptoms. Each symptom was recorded as a binary outcome of occurrence, yes or no, and scored 1 or 0 respectively. Symptom intensity included mild, moderate, and severe and scored 1 to 3. Frequency included daily, few times a week, once a week, 2 to 3 times per month, once a month, and less than monthly, and scored from 6 down to 1. Scoring each prodromal item was scored and summed. The global score is achieved by summing all of the items together for a total possible score of 90. The data were presented using descriptive statistics, means, standard deviations, and proportions. Internal structure of the prodromal symptom screening scale was examined by principal component factor analysis with oblique rotation. Factors were abstracted based on 2 criteria: eigenvalues greater or equal to 1 and factor loading greater or equal to 0.3. Pearson's product moment correlations were used to examine the relationship between factors. Our hypothesis was that the prodromal symptom screening scale may have a 2-factor structure reflective of typical symptoms of acute coronary syndrome and the subjective and individual anginal equivalent symptoms suggestive of CAD. 191 patients were assessed for eligibility. Of those, 120 were included. 71 were excluded for various reasons because they were too tired, they had too much pain, the study was too involved, a family member refused, and they were not interested. The acceptance rates for the enrolled equaled 63.4%. The mean age of the ACS patients was 67.6 years. 50% were male and 60% had unstable angina and 40% had non-ST elevated myocardial infarction. Most were Caucasian at 98.3%, married at 68% and retired at 61%. The overall total score for the prodromal symptom screening scale was 22.6, with most participants describing at least 2 prodromal symptoms prior to their cardiac event. 6 participants reported experiencing no prodromal symptomology. The majority reported that they had prodromal chest pain, fatigue, shortness of breath, and anxiety, with headaches and dizziness reported less often. To assess potential utility of the prodromal symptom screening scale in an individual self-report instrument, to identify people at risk for coronary artery disease, we looked at relationships between demographic variables of age, sex, and education level. The differences in report of prodromal symptoms between older age, greater than 65, and younger was also looked at, along with educational level. In particular, there were significant differences in prodromal scores between older and younger adults. Younger adults had higher scores of the prodromal symptom screening scale than older, and however, there was no significant difference found among participants' educational level and/or gender. A breakdown of item 9, the qualitative item on the prodromal symptom screening scale reported by participants, it's provided in this table here. 65 participants reported other prodromal symptoms, with no significant difference according to sex. The 5 most other prodromal symptoms reported were gastrointestinal symptoms such as nausea, vomiting, flatulence, and heartburn, diaphoresis, numbness and tingling and burning in the legs and arms, palpitations, and cognitive symptoms such as confusion, memory loss, uncertainty, or blurred vision. The prodromal symptom screening scale is a 2-factor structure and had accepted eigenvalues greater than 1. So for factor 1 and 2, they had eigenvalues of 2.23 and 1.4 respectively, and explained 24.7 and 15.6 of the variance, and together 40.4 of the variance all over. Kaiser-Meyer-Olkin measure of sampling adequacy exceeded the recommended 0.60 and was reported at 0.64 with a p-value less than 0.001. The specific prodromal subscale, factor 1, included unusual aches and/or pains, dizziness, chest pain, and the other prodromal symptom category, item 9, with accepted factor loading ranges between 0.46 to 0.77. The general non-specific prodromal subscale, which is factor 2, included unusual fatigue, sleep disturbance, headaches, shortness of breath, and anxiety, with accepted factor loadings ranging between 0.4 to 0.75. Pearson correlation confidence was 0.44 with a p-value greater than 0.001 between factor 1 and factor 2. The construct validity, the analysis revealed a 2-factor structure with all factor loadings ranging from 0.44 to 0.77. The other prodromal symptom item number 9 had the strongest factor loading on the specific prodromal symptom subscale. This may suggest a more detailed examination and further item generation is required of the different yet important symptoms reported by patients in the other prodromal symptom category. Sleep disturbance was the strongest factor to load on the general non-specific prodromal symptom subscale, with significant inter-item correlations with shortness of breath and anxiety. It is interesting that the general, or rather, those non-specific prodromal warning signs captured by factor 2 on the actual prodromal symptom screening scale have been previously described by others as symptoms that are often hard to describe, are elusive, vague in nature, and totally unexpected. There are limitations in this study. Criterion, concurrent and divergent validity, sensitivity, specificity, responsiveness, and positive predictive value of the prodromal symptom screening scale will be needed to be established through future analysis. Homogeneity of the current sample in terms of age, geographic location, and limited ethnicity is also a factor. Subsequent psychometric evaluation of the prodromal symptom screening scale should include a multi-large, diverse sample that includes the full acute coronary syndrome designation, which would include unstable angina, non-ST elevated myocardial infarction, and ST elevation myocardial infarction. Implications for practice with further item generation and follow-up psychometric testing of the prodromal symptom screening scale may be used preemptively as a screening tool to identify men and women who may be likely to develop or have exhibited prodromal symptoms related to coronary artery disease. In conclusion, this is the initial study to establish the preliminary psychometric properties of the prodromal symptom screening scale with potential utility in current clinical practice in a sample of acute coronary syndrome patients. The 9-item tool would be easy to use in a clinical setting to assess prodromal symptoms in men and women. However, further psychometric property assessment of the tool is necessary to further clarify wording of the items and determine inclusion and exclusion of scale items. For more information, visit us at our website or email me with the information on the screen. Thank you very much.